We now move on to the next session on lung infections. I invite the chairpersons for this session, Dr. Prabhavati Banerjee and Dr. Dibendu Roy Chaudhuri. And the topic is resurgence of necrotizing pneumonia. And the speaker is none other than Dr. Balasubramaniam. Dr. Agarwal, please collect your memento from the memento corner. Yes, Dr. Prabhavati Banerjee needs no introduction in Bengal. She's the former professor of pediatrics, Medical College, Kolkata, and the former prof of pediatrics, MGM Medical College, Kishanganj, Bihar, and she's the former president of the WBAP. Dr. Dibendu Roy Chaudhuri. Dr. Dibendu Roy Chaudhuri is the associate professor pediatrics, Medical College, Kolkata, and his areas of interest are nephrology, neurology, pulmonology and infectious diseases. He has publications in several journals, and he's the vice president of the West Bengal Academy of Pediatrics 2023.
Now we are having a very interesting session, that is resurgence of necrotizing pneumonia. Now, after giving and having a good number of vaccination in children, still we are getting this type of pneumonia. Let us see what is the background behind and how to manage these children. Now our speaker is none other than Dr. Balasubramaniam Sundaram, and I invite him to give his lecture. Yes, sir.
Thank you very much. We move from a vaccine topic to a vaccine replacement topic, namely resurgence of necrotizing pneumonia. In the next 15 to 16 minutes, let me try to see what is necrotizing pneumonia. Is there really a resurgence of necrotizing pneumonia? And briefly, I will deal with the clinical features, diagnosis, radiological diagnosis, and the management with specific reference to antibiotic. That is what most of you in the audience would be interested. Before I start, let me ask you, the audience, how many of you feel there is a resurgence of necrotizing pneumonia in the recent past? Please raise your hands. How many of you don't feel the same? It's all the same. Okay, that's nearly equal. Let's see what literature says. Let us move on with the case scenario where an 8-month-old came with fever and had tachypnea. Rightly, somebody started oral amoxicillin 50 milligram per kg, and it worsened. And somebody did a total count, 25,000. The child had retractions and borderline saturation with tachycardia. CRP was 200, and an X-ray was taken. And all of you can make out that there is a round pneumonia in the right upper lobe. When you have high counts, high CRP, round pneumonia, you always diagnose what? Pneumococcal pneumonia. That's what I also diagnosed. I did a blood culture. Of course, now any child who goes to ICU, we get an NPA biofire. Ceftriaxone was started. And in spite of good dose of antibiotics, supportive measures, day 5, the high fever is persisting. And of course, the X-ray was repeated. Now you see the difference when compared to the previous X-ray. What was a round pneumonia is showing some round shadows inside. Now the question is, in spite of good antibiotic, this child worsened. What are the causes? It could be a drug resistance, MRSA, or it could be adenovirus, it could be fungal if it is immunocompromised, or it could be any complication of a community-acquired pneumonia which could start from necrotizing pneumonia, empyema, or a lung abscess. Of course, non-infective causes obstruction has also got to be thought of. My question is this necrotizing pneumonia? And if it is so, what is the definition of necrotizing pneumonia? We are not pathologists, we are clinicians. We don't do biopsies to diagnose necrotizing pneumonia. Basically, necrotizing pneumonia is a severe pneumonia. It's not run-of-the-mill pneumonia described by WHO algorithm. And where there is some cavitation, there is some liquefaction necrosis inside the lung. And invariably, there will be some pleural involvement. But pleural involvement degree may vary, pleural involvement may not be there. That is necrotizing pneumonia. The next question is, what is the incidence of necrotizing pneumonia? Is it going up in India? What about the worldwide incidence? Is there a true resurgence or a pseudo-resurgence? Literature data clearly shows that there is increase in necrotizing pneumonia, starting from UK to US to Europe, everywhere. They have been reporting more number of cases. You must be wondering why this is so. It is because of two reasons. What are the two reasons? We'll look at the Indian data and look at the reasons. What about Indian data? Our own president, Dr. Basaraj, 2014 president, published in Journal of Pediatric Critical Care, nearly about 1,000 and odd cases of community-acquired pneumonia. Only 3.3% was necrotizing pneumonia. And in another study published by pediatric surgeons and intensive care specialists, they reported only 3.7% of community-acquired pneumonia was having necrotizing pneumonia. And in both the studies, the commonest organism was only Staphylococcus. Now, after this topic was given to me, I searched our own hospital records the last 10 years. Interesting data. Definitely we are going to publish it. We came across 30 cases of really proven necrotizing pneumonia. Surprisingly, 26 of them were previously healthy. 4 had some underlying morbidities like asthma, 1 had hemolytic uremic syndrome, 1 had nephrotic syndrome. 6 of them required respiratory support, including HFNC in 2. And 14 underwent CT, only 14. 16 did not undergo CT. And we had an ultrasound done for all these cases. And of course, ICD was inserted in 15 and no deaths. Coming to the microbiology, in the microbiology, this is what we found. Out of 30 cases, 10 cases we could identify the bugs. That is because we are very aggressive in trying to detect pneumococcus. We did Binax, not 9X, it is Binax in the pleural fluid, rapid pneumococcal antigen test, pleural fluid culture, blood grew pneumococcus in 3, MRSA was there in 1, Burkholderia was there in 1, and 20 out of 30 we had no bugs, and 90% of the cases recovered with ceftriaxone and clindamycin inpatient, followed by clindamycin or amoxiclav as step-down therapy outpatient. Coming to the resurgence, yes, over the last 2 decades, increasing numbers are reported. And the problem has become more, mainly because we have been doing more CT scan, more ultrasound for pneumonias. If you do only an X-ray, what you will find is only an opaque shadow and we will think it is consolidation. But if you do ultrasound, you will pick up liquefaction. If you do CT, definitely you will pick up the necrotizing pneumonia. That might be the reason why there is more incidence of necrotizing pneumonia. Coming to the vaccine and necrotizing pneumonia, in the UK, when PCV10 was introduced, 13 was later introduced, there had been a resurgence of necrotizing pneumonia. People were very angry that the vaccine was failing. And 3 and 19, as discussed by the previous speakers, were the most common organism. But fortunately, in most countries where there is PCV13 implementation, the number of cases of necrotizing pneumonia had not gone up, indicating pneumococcal vaccination does not increase non-serotype necrotizing pneumonia. What about the etiology? We all think that when it is necrotizing pneumonia, it is always Staphylococcus. Unfortunately, it is not. Most necrotizing pneumonia is pneumococcal, unless proven otherwise. Staphylococcus in Indian data, the incidence is high mainly because pneumococcus is not being looked for that vigorously. But now research studies are going on, we'll pick up more of pneumococcus than before. And there may be other organisms which could include Klebsiella in a young infant, which can cause bulging interlobar fissure and necrotizing pneumonia. H-flu is on the way out. And you can have any organism starting from Streptococcus to all sorts of anaerobes. Coming to the next controversial topic, if you go through the Chinese data, you will find next to pneumococcus, it is not Staphylococcus, which is the cause for necrotizing pneumonia in China. It is all Mycoplasma. Most of the pneumonias in China next to pneumococcus are due to Mycoplasma. They are proven. They are proven with PCR. They are proven with 4-fold rise in IgM titers. There is hardly any data in India. In fact, our own study on Mycoplasma, 20% of community-acquired pneumonia below 5 years we published was due to Mycoplasma. But we had only 1 case of Mycoplasma in which there was necrotizing pneumonia. Indian data is very sparse, and we do not know whether it is a co-infection or a solo infection. And more frightening, 85 to 90% of Mycoplasma in China are resistant to azithromycin. India, there is hardly any data. In our own experience, we find that azithromycin is not working. Whatever cases of mycoplasma, azithromycin does not succeed. And most of these cases, we had to resort to give doxycycline or levofloxacin if not responding. And this is one case of mycoplasma pneumonia which got admitted in a benign state with only tachypnea, went on to develop massive pleural effusion, in which we proved mycoplasma with a pleural fluid PCR and 4-fold rise in IgM titer. And we couldn't identify any other organism. This child, we had to give levofloxacin, had to be ventilated also. Coming to the clinical features, how does a clinician diagnose necrotizing pneumonia? Very simple. The important point that you must remember, unlike your gram-negative pneumonia, unlike Pseudomonas pneumonia, Burgdorferi pneumonia, necrotizing pneumonia most often occurs only in healthy under 5s. Our own normal children below 5 years, majority of them. It's not a disease which occurs in immunodeficient children commonly. But the point is, these children are disproportionately sick with respiratory distress, lot of grunting, hypoxia, and they get worse and they develop progressive pneumonia. May have pleural effusion or empyema, and if you find the pneumothorax or if you find the pleural effusion or a bronchopleural fistula, your diagnosis of necrotizing pneumonia is confirmed. How do you confirm? Interestingly, if there is an underlying shadow within the shadow in a consolidation, and if there is pleural effusion with an irregular consolidation in the chest X-ray, it will give you a clue that it is necrotizing pneumonia. Though you will have to do ultrasound or CT to confirm there is liquefaction necrosis underlying the area of consolidation. Look at this chest X-ray. This child had clinically a severe pneumonia. The X-ray was like this. We were not sure whether this is a simple necrotizing pneumonia with 2 pneumatoceles or whether this is a lung abscess. In such a case, definitely further imaging is required to confirm the diagnosis and manage the child appropriately, which may include an ultrasound. What about CT thorax? Nowadays, CT thorax is available left and right, and you try to do it whenever the pneumonia is not responding to your antibiotic for whatever reason. Of course, the gold standard for diagnosis is CT thorax, because unlike X-ray, it picks up a liquefaction under the consolidation. You find gas or solid-filled cavities inside. And definitely CT scan is the one which is the gold standard for diagnosis. Look at this CT scan, where in the mediastinal window, you find there is an enhancement which is heterogeneous in the parenchyma of the left lower lobe. In addition, there is also atelectasis. In addition, there is also a pleural effusion. Another CT thorax in which an X-ray did not pick up any cavities at all. The X-ray showed only consolidation, minimal pleural effusion. But then the CT was frightening. Both the cases, one in the upper zone and one in the lower zone with pleural effusion. We are shocked. So CT will surprise you, But then ultrasound is available for all of us. How good is it? In fact, more and more studies are showing ultrasound is good enough. In fact, in our own institution where we have a very experienced pediatric radiologist, he will criticize us if we do CT. Only when we think of a surgical intervention, we go for CT. Otherwise, we go by ultrasound. CT is as good as ultrasound. In fact, look at this patient who underwent both CT and ultrasound. Whatever CT found in the form of a massive left effusion with heterogeneous enhancement and round necrotic shadow, the same thing has been picked up by the ultrasound as shown in the right. But the problems are CT is costly, radio-invasive, and it's not easy to do CT in a child who is being ventilated or in an ICU, who is there in the ICU critically ill. And of course, when we have a resource limitation, always CT is difficult. Ultrasound, excellent, but the biggest problem is that it is operator dependent. You need to have somebody who is experienced in pediatric radiology who will come to the bedside and do an ultrasound to give you a diagnosis. The next problem area is the microbiological diagnosis. Blood culture, hardly you will get anything, less than 10%. Pleural fluid cultures, yield is good. Binax test in pleural fluid, excellent diagnostic tool for pneumococcal pneumonia. Sputum culture only in older children, and you can't be doing BAL for stable children unnecessarily. Look at this child who had a progressive pneumonia and who was treated over a period of a week. This is about 2019. What happened? We went on doing one test after another. First, we did a viral PCR, it obliged with 3 viruses. Then we did a scrub typhus IgM, it obliged with IgM positivity. Then we did a mycoplasma IgM, it obliged with my IgM positivity. So does this pneumonia get caused by all the 5 pathogens? This is the problem in doing all these multiplex PCR panels. Look at the availability of a new panel. You try to identify 33 targets, but the problem is these tests are so sensitive, you may end up picking up more than 3 or 4 bugs and you don't know, you end up in a confusion which to treat. But unfortunately, these tests are now becoming more quantitative than qualitative. In the next 5 years, we will have good panels which will tell you that this is the bug which is causing the necrotizing pneumonia, rather than just give a report of 4 positivities. Is there an algorithm for the practitioner for necrotizing pneumonia? Let me try it, and I just modified this, available from the NHS website. If you have somebody with a community-acquired pneumonia, severe enough to result in hospitalization, yes, you start ceftriaxone, you do all these tests including Legionella workup, isolate the child, and then also do all the respiratory cultures including PCR from the pleural fluid, BAL, tracheal aspirate, sputum, etc. With regard to treatment, which is what is important for all of us, what do? Our standard protocol in our institution, based on our own cultures, is ceftriaxone plus clindamycin to cover pneumococcus and MSSA and MRSA sensitive to clindamycin. For MSSA, we don't add cloxacillin. If it is severe, we consider adding linezolid plus clindamycin, these 2 drugs alone. Severe disease or toxic shock syndrome, we give IVIG and we add rifampicin. And if for any reason this child reports come sensitive to clindamycin, we give only clindamycin and rifampicin and stop linezolid. If it is clindamycin resistant, we continued linezolid with clindamycin. On the other hand, if the same child with necrotizing pneumonia, if it becomes hemodynamically unstable, we always go for big guns, vancomycin and meropenem. Meanwhile, if the child is not improving and there is an increasing failure to ventilate, then what we do, we think of resistant bugs and go for multiplex PCR and other invasive investigations. Meanwhile, we do a CT thorax to exclude abscess, empyema, non-infectious causes. And of course, in such cases, we do consider second dose of IVIG, which may reduce the mortality. Coming to the antibiotics, in necrotizing pneumonia, the standard practice is to start with ceftriaxone and clindamycin and scale it up depending on the clinical features. 2 to 6 weeks is the minimum duration. You can step down to oral once the ICD is out or the child is very stable. As long as there is an intercostal drainage, you are supposed to give IV antibiotics. And the total duration may vary from anywhere to 4 weeks. In our own study, the mean duration has been 5 weeks. To summarize, the important take-home messages will be as follows. Necrotizing pneumonia, is it resurgent? The answer is yes. It is because of more incidence due to vaccine replacement and also because of more recognition due to more use of CT. Any non-responding pneumonia, every pediatrician should suspect necrotizing pneumonia. Most with necrotizing pneumonia do not have a chronic illness. And pneumococcus is the commonest cause of necrotizing pneumonia. PVL producing staph aureus, both MSSA and MRSA are on the rise. X-ray plus ultrasound performed by a good pediatric radiologist is enough. Avoid CT whenever it is possible. If you think of surgical intervention, please do a CT. Antibiotic therapy, 4 to 6 weeks, cures most necrotizing pneumonia. Ceftriaxone plus Clinda is the best choice for necrotizing pneumonia. Call the surgeon whenever you are in trouble. By and large, the prognosis is excellent. Thank you very much. Please give your feedback and questions, if any. Thank you.
Bala sir, Thank you very much for your talk. Uh, Hello. Yes. Balasubramaniam, thank you very much for your talk, sir. One question. As you are telling that pneumococcus is the commonest cause for necrotizing pneumonia, even in your study, you demonstrated that that was the commonest cause. So why these bugs are not responding to the standard therapy against pneumococcus, like for example, plain amoxicillin or camoxiclav? Because in a normal case, they should respond well. So why your cases of necrotizing pneumonia by pneumococcus, they are not responding to the standard therapy? And what's the reason? Are they different strains or something else?
It's a very good question, pertinent question. In fact, we have been, in our institution, we have been following pneumococcus for the last 20 years. We have data from our own institution. Penicillin resistance, when we started looking at pneumococcus, was only around 16%. In fact, in the previous lecture for the vaccine, in the ACIP study in which we were part of it, our penicillin resistance was only 14%. Today, in our own institution, our penicillin resistance is 45%. 45%. Fortunately, the penicillin resistance is not as high as in meningeal isolates. In isolates from the blood and isolates from the pleura, penicillin resistance is to a tune of 20 to 30% in our center, where it was only 10 to 14%. So one of the reasons why it is not responding to amoxicillin could be, one, penicillin resistance. They are all universally resistant to cotrimoxazole and macrolide. Macrolides won't work. Two, the second reason, once there is pus, the bugs don't allow the antibiotic to enter. That is where your clindamycin or your linezolid could work better even in pneumococcal pneumonia when compared to penicillin or amoxicillin. Presence of pus prevents the bugs being acted upon with any aggressive antibiotic. That could be the reason. And the third important point, most of these necrotizing pneumonias have associated parapneumonic effusion and empyema. And as we all know, antibiotics will never cure empyema. Only a surgeon can cure an empyema.
Dr. Bala.
Again, only ceftriaxone which will not act against penicillin resistance.
No, ceftriaxone. No.
Vancomycin would work.
No. Penicillin resistant pneumococcus is likely to respond to ceftriaxone. In our own data, in lung isolates and blood isolates, we have not had ceftriaxone resistance. Ceftriaxone resistance has been observed by us and in CMC Vellore only in the meningeal isolates. Ceftriaxone resistance in pulmonary ear isolates is exceedingly rare. That's my answer to your question. We don't give amoxicillin for... One of the reasons why we give ceftriaxone for severe pneumonia is to cover penicillin resistance. And you give vancomycin if you think your ceftriaxone is not working to cover one, ceftriaxone-resistant pneumococcus and MRSA causing bacteremia. Unfortunately, vancomycin does not penetrate well into pus, does not penetrate well into lung. There is good data in adults that linezolid is as good as vancomycin even in bacteremia, though pundits in infectious diseases are averse to giving linezolid upfront. And linezolid also will cover pneumococcus very well, even the penicillin-resistant pneumococcus.
Dr. Bala, one more.
Thank you, sir, for this nice deliberation. What to add? What is our experience in the recent adenovirus upsurge? You have seen there are multiple cases. There is association between the adenovirus and the necrotizing pneumonia.
I didn't go into that. There are anecdotal reports. There is one report in Indian Journal of Pediatrics also, adenovirus causing necrotizing pneumonia. Dr. Kundu is here. They have seen adenovirus pneumonia causing necrotizing pneumonia. But then these reports are very scarce. We do not know whether it is polymicrobial or only viral. Even tuberculosis can cause necrotizing pneumonia. Fungus can cause necrotizing pneumonia. I didn't want to deal with those uncommon presentations.
Thank you, sir,
Thank
for your
you.
nice deliberation. Thank you all. Thank you.
Thank you, Bala sir, for the excellent presentation.